Hello, my name is Nadeem El-Kouri, and I'm an emergency medicine resident here at the University of Oklahoma. Thank you to the Office of Interdisciplinary Programs for having me, and to the audience members for joining me today. I'd like to talk about our project to use nasal swabs for the de-escalation of vancomycin for patients with suspected methicillin-resistant Staphylococcus aureus, also known as MRSA, infections. I'd like to introduce the whole team. Dr. Genchis is an emergency medicine faculty member and chairman of the Antibiotic Stewardship Committee. Tashrique Rahman is a pharmacy resident who built this protocol. Here are some of the interprofessional educational competencies that we address. In short, we place patient interest at the center of interprofessional healthcare delivery, specifically through education and interventions aimed at physicians, APPs, and pharmacists. By using evidence-based practices, we can minimize patients' exposure to the unnecessary antibiotic therapy and associated risks. I want to be clear that not all vancomycin use is unnecessary, but there are times when a patient may be de-escalated and they may be continuing to receive it needlessly. And I also want to clarify that not all antibiotics are bad. Antibiotics are a very powerful tool in a clinician's toolbox and have a significant role in treating certain patient populations. The goal is therefore not to eliminate all antibiotics, but to ensure they're being used appropriately. This is especially important when considering that more than half of all hospitalized patients will receive antibiotics at some point in their stay. Of those, about 30% are deemed either unnecessary or suboptimal. That's considerable when you think of the sheer number of patients that we're talking about. Unfortunately, like seemingly everything else, COVID has made selection of antibiotics worse. Recent findings from 2 systematic reviews have identified that 72% of patients with COVID-19 received antibiotic therapy despite only 7% having a bacterial co-infection. The more antibiotics you're exposed to, the more likely you are to experience adverse events, including allergic reactions, development of resistant infections, or deadly sequelae like diarrhea, to name a few. On the right, we see the CDC's guidance for reducing antibiotics. It starts with figuring out what bug or bugs you're specifically fighting against. It's important to do this via culture before antibiotics are given, because antibiotics can throw off the clinician's ability to determine the culprit bug. Then you do a consistent review to ensure the indication, the dose, and duration are all specified, not only initially, but recurrently, to ensure they remain necessary. So let's talk more about our specific project and talk about the infamous MRSA, which stands for methicillin-resistant Staphylococcus aureus. Now, this is important because the methicillin-resistant modifier indicates we're talking about a superbug. So briefly, Staphylococcus aureus is very common and is abundantly, and for most of us, harmlessly present on our skin. This has developed over time resistance to penicillins. Then penicillins were made and modified to specifically fight off these resistant strains of Staphylococcus aureus. These penicillins were classified as anti-staphylococcal penicillins, and unfortunately, resistance developed to these as well. Resistance also developed to a structurally similar antibiotic called cephalosporins. So now the backstop medication that we use is vancomycin. If this is used inappropriately, we can put evolutionary pressure and precipitate resistance to vancomycin as well, then putting us between a rock and a hard place in terms of how we're able to treat these infections. So as a reminder, this is a serious bug which can cause deadly infections in the blood, in the lungs, or at surgical sites, to name a few. It's also worth mentioning that with broadly equal MRSA culture percentages to other systems or other hospitals in our health system, we use twice as much vancomycin as some of our sister facilities. That's pretty significant. These days, even the mention of nasal swabs strike fear into the hearts of many. So I apologize for giving many of you PTSD with this picture on the right. The nasal swabs we're talking about here, though, aren't like the COVID ones that seemingly require you to tickle somebody's brainstem to get a good sample. Instead, the ones we're talking about today are intended to swab just the inside of the nose. It turns out that if someone has MRSA, they are likely to be colonized by it in their nose. If they are colonized, they are at greater risk of developing infection from it. Strategies have already been shown to reduce total exposure to anti-MRSA agents by 2 days. And here's the important part, without any impact on clinical course. And this is huge. Additionally, there are evidence-based strategies showing a reduction in total dosages of vancomycin. This equates to a decrease in vancomycin-related adverse events and a decrease in the probability of antibiotic resistance. So let's talk about these strategies. So our intervention is a multidisciplinary two-pronged approach based on the literature. So it's necessary to educate physicians, APPs, and pharmacists about this literature, which has shown efficacy of nasal swab PCR to screen for MRSA. Nasal swab PCR has been shown to have a negative predictive value of 98% for detecting MRSA. There have been concern that it may not be a good indicator if infections at other locations, and this was disproven as it has a negative predicted value of 94% for lower respiratory sources of infection. Additionally, we'll educate them that although the current standard is culture, that can take up to 96 hours. A nasal swab, on the other hand, can produce trustworthy, finalized results in as little as 1 to 2 hours, or up to 48 hours, depending on the equipment used for testing. This is a significant improvement in time. Next, we need to ensure that the nasal swabs are actually being ordered by targeting one of the largest gateways into the hospital setting, the emergency department. It's in this setting where antibiotics may be started before culture or PCR results are finalized. Here's some preliminary data from our efforts. We audited the charts of 50 random vancomycin orders to see how many had nasal swabs ordered prior to vancomycin initiation, before we went around and educated anyone. Here's what we found. Prior to the intervention, on average, out of 50 vancomycin orders, 81% did not have a nasal swab ordered. This is indicated by the orange slice of the top left pie chart right here. That means 19% were ordering nasal swabs before the intervention. So let's talk about the results of these. Of the 19%, 68% had a negative MRSA result, and 32% had a positive MRSA result. This is consistent with prior evidence stating about a third of people are colonized with MRSA. Now, after the intervention, which happened in November, only about 52% of patients did not have a nasal swab ordered of the 50 vancomycin charts that were audited. Of the 48% that had a Nares Swab ordered, 85% had a negative MRSA result and 15% had a positive MRSA result. So that's good. You can see already that the number of nasal swabs has increased as a proportion to the number that were audited. Here's a graph of the number of negative MRSA swabs and the number of days of vancomycin therapy. So remember, the intervention took place in November 2020. The lines represent the average of the bars for the pre and post. So this is the pre, and this is the post, November and December post. And if we look at these two blue bars, the average of these two values is represented by this bar right here, and comes out to 20.5. So now if we compare the blue line on the left and the blue line on the right, we can see an increase in the number of negative MRSA swabs. Not surprising, we're testing more, right? That's good. that demonstrates or suggests at least that the educational intervention did indeed lead to practice modification. That's what we want. Now, similarly, if we look at the orange lines, we can see that the average length of therapy for vancomycin went from 8.4 days to 7.3 days. Now, this is a small but modest decrease, and our goals are to study this further and see on a longer time course if there's a sustained increase in the number of swabs that are ordered and the impact on vancomycin therapy duration hospital-wide. Here are my references. Thank you for your time.